Hello, everyone. My name is Michael Pierpling, and I'm a PGY6 cardiology fellow at the University of Kansas Medical Center. And I'm very pleased and grateful to be able to present at the Greater Kansas City Echo Symposium. And I'm here today to discuss just some interesting cases that have come through our echocardiography laboratory recently, and hope you find them interesting as well. I want to thank everybody for your attendance and interest in this. And I have no conflicts of interest to disclose. We will start with our first case. This is a 61-year-old male. He presents to the echocardiography laboratory via his primary care physician with an asymptomatic murmur that was auscultated on routine physical exam. His past medical history is notable for hypertension and dyslipidemia. He has no notable family or surgical history. And due to his body habitus, some of the pictures are technically suboptimal, but here we will start with a parasternal long axis shot. And we can already see here that there is some pathology going on with the aortic valve. We can see that the coaptation point is not midline, and it does appear to be thickened. Taking a closer look, we can see that there is some restriction and thickening of the aortic leaflets with the non-midline opening point. And we can also see here that the ascending thoracic aorta is quite dilated. In fact, in later measurements, it actually appears to be 6 centimeters in diameter. Taking a closer look at the valve here with a parasternal short axis view, we can actually see that the valve appears to be bicommissural, which was a new finding for this patient. And in concert with his ascending thoracic aorta aneurysm of 6 centimeters, this is quite serious. And we can see here an additional biplane view. We can see nicely this bicommissural aortic valve. And in concert with that ascending thoracic aorta, this requires prompt consultation with cardiology and cardiothoracic surgery. And his workup is currently ongoing on an urgent basis. And so the bicuspid valve was actually first described by Leonardo da Vinci over 500 years ago. We can see his initial sketchings and musings up in the upper right corner, and he found that the tricuspid valve appeared to be the most ideal valve in terms of flow characteristics, and did find bicuspid valve, which did appear to have some degree of stenosis, and he did describe that. It is one of the most common congenital valve abnormalities. It affects approximately 1 to 2% of the population. It can be complicated by valvular aortic stenosis and insufficiency, and it's associated with an increased risk of infective endocarditis. The commissural calcifications likely lead to premature stenosis. There also are associated aortic wall complications, which need to be monitored closely and have their own parameters for monitoring and replacement. This is especially true as aortic aneurysms, as well as dissections and coarctations, can be concomitantly found. Screening is also recommended for first-degree relatives, and there is an increased association with intracranial aneurysms in these patients. And this is just a flowchart as recommended by the Society of Thoracic Surgery, with confirming the bicuspid valve diagnosis as well as monitoring first-degree relatives. It's also important to actually identify the degree of valvular dysfunction in terms of stenosis or regurgitation per normal guidelines. And then monitoring as well very closely the ascending thoracic aorta in terms of cross-sectional imaging in addition to echocardiography, as there are different guidelines in relation to replacements and surgical intervention earlier in these bicuspid valve patients as opposed to standard tricuspid valve patients. On to our next case. This is a 36-year-old female. She has a past medical history notable for an asymptomatic murmur, but no previous workup. She presents to the echocardiography laboratory. There is no known personal or surgical medical history. There was a family history notable for a subtype of valve surgery in her brother as a teenager, although the type and extent of this valve was not known at the time. We will go ahead and start with the parasternal long axis view. And we can already see that the biventricular function and size appear to be normal, as is the mitral valve and left atrium. The aortic valve, though, does appear to be severely restricted, thickened with a very asymmetric opening. And on to collar Doppler pictures, we can now see that there is some degree of aortic regurgitation as well as some turbulent flow. And to help delineate the anatomy further, we will now look at the parasternal short axis view. And we can actually see here that there is a unicuspid valve causing some degree of stenosis as well as regurgitation. And so the unicuspid aortic valve is a very rare finding, approximately 0.019% incidence, typically found at age 35 plus or minus 15 years when it's first discovered. It typically presents with stenosis, regurgitation, but most commonly a mixed lesion, although it tends to be more stenotic than regurgitant. Many times the surgical specimen actually defines the diagnosis, given that there's a lot of similarity and overlap on appearance on echocardiography with bicuspid valves as well. Approximately 76% of these patients were found to have aortic root or ascending aortic dilation. Approximately 27% of these patients had additional cardiac structural abnormalities, and approximately 11% had family history of congenital aortic valve disease, although no identifiable gene or unicuspid predominance of the abnormality has been found. And surgical intervention is ultimately curative once surgical indicative parameters are met, and the outcomes are similar to any other patient with aortic valve surgical intervention. On to our next case. This is a 46-year-old asymptomatic female. She presents with the cardiovascular clinic to establish care, more so to undergo a preventative workup per her behest. There is no pertinent past medical history. The patient reportedly was found to have an abnormal valve or quote mitral prolapse murmur when undergoing workup for palpitations during pregnancy, but there wasn't any known cardiovascular follow-up. There's also no pertinent family history. We will go ahead and start with a parasternal long axis view. And we can see that the biventricular function is preserved. Cardiac chambers appear to be normal size. Mitral valve does not appear to be significantly abnormal, at least in this initial view. And then the aortic valve also appears to be coapting midline. It appears to be thin leaflets, and the aortic root appears to be normal size. We will now look at collar Doppler. And although this is technically suboptimal, we can see that there is some degree of aortic insufficiency, which would be a little unusual in this patient. And then to help look at the anatomy of the aortic valve, we will now look at a parasternal short axis view. And here we actually see that there is a quadricuspid valve with 4 equal-sized leaflets, although there can be multiple leaflet morphologies in these patients. This is also known as a clover leaf. So the quadricuspid valve is very rare with a very minuscule incidence. The mechanism of dysfunction is typically regurgitation, more so than stenosis. And hemodynamically significant lesions typically manifest in the 5th to 6th decade of life, ultimately requiring surgical intervention. Other congenital heart defects can be present in approximately 18 to 32% of these cases, with the predominance of coronary artery anomalies. And 26 to 42% of these cases also demonstrated concomitant aortic dilation. Aortic valve repair with either bi or tricuspidalization of the quadricuspid valve can be considered versus traditional valve replacement. And on to our next case, we have an 81-year-old male veteran with minimal past medical history, mostly due to medical avoidance for many years, presents to the VA with complaints of severe fatigue and dyspnea upon exertion while working on his farm. There was no significant past medical history noted in the chart. However, the patient had not routinely followed up with any healthcare providers over many decades. He had never had any cardiovascular workup to speak of. He reports no significant family history that he can recall. He does report a history of remote tobacco use and multiple animal and chemical exposures while working on his farm. And as part of his workup, he was sent for echocardiography. And we will start with an apical four-chamber view. And we can see that biventricular size and function appear to be normal, as do in this limited view the tricuspid and mitral valves. But interestingly, noting there is a septation dividing the right atrium. We'll take another view looking at this septation here. Ultimately, this patient was found to actually have a neuromuscular source of his fatigue and shortness of breath and is undergoing workup for myasthenia gravis currently. But incidentally, he was found to have this cor triatum dexter, or CTD, which is found in the right atrium. This is extremely rare, less than 0.1% of congenital defects. Cor triatum sinister, which is the left atrial septation, is the more common variant. So during embryogenesis, the right valve of the right horn of the sinus venosus divides the right atrium into two to direct oxygenated venous return from the IVC across the foraminal valley. Normally, this valve regresses at approximately 12 weeks gestation and leaves behind the crista terminalis proximally, eustachian valve of the inferior vena cava, and the Bayesian valve of the coronary sinus distally. If there is any persistence of this, it can result in separation of the right atrium, causing cor triatum dexter. The symptoms of cor triatum dexter depend on the degree of obstruction or septations left of this septation. Presentation of cor triatum dexter can vary from asymptomatic, as this patient was in his 80s and found incidentally, but depending on the degree of the septation, it can also be associated with severely elevated central venous pressures, even up to right heart failure and atrial arrhythmias related to these elevated pressures. It can also be associated with additional right-sided defects, such as tricuspid abnormalities, Epstein anomaly, pulmonary valve stenosis or atresia, and ASDs. And treatment can vary from watchful waiting to percutaneous or surgical fixation, it all depending on the degree of the obstruction or hemodynamic significance of what's left of this septation. And now we have our next case. This is a 39-year-old male with a past medical history of ongoing methamphetamine abuse, likely drug-induced heart failure with reduced ejection fraction, with the left ventricular ejection fraction around 15%, previous DVTs and PEs with known medication noncompliance, and he presented to the emergency department with symptomatic acute on chronic heart failure exacerbation. As part of this workup, he underwent a transthoracic echocardiogram, and the following image was obtained. And we'll take a look at an apical four-chamber view. We can see here severe left ventricular dilation, as well as severe left ventricular dysfunction. And we can see here a highly mobile left ventricular thrombus. And we now see it exiting the left ventricle. We'll take one more look at this loop. So at the time that this was noted, the patient was quickly stroke activated, underwent CT and neurological consultation. He was found to have both acute and chronic multiple small MCA infarcts. However, there was no large vessel occlusion, which was amenable to any thrombectomy. The patient was ultimately resumed on anticoagulation. Unfortunately, the patient did leave against medical advice, although he did return 2 weeks later and found to have additional CVAs with additional neurological sequelae. Unfortunately, this was after not resuming his prescribed anticoagulation. Thank you all so much for your time and attention. I wish you all the best. Have a wonderful day.